Well, good evening, everyone. Thank you for joining us for tonight's Menopause Chat. This is the third of a series where we talk about different topics that are related to midlife and menopause. And tonight's topic is preventing, recognizing, and treating cancers in midlife women. And I'm thrilled to be joined by Dr. Eav Lim, a gynecologic oncologist at WellSpan, and Dr. Heather Thieme, a surgical oncologist at WellSpan. So, as many of you may know, October is Breast Cancer Awareness Month, and it's a great opportunity to remind ourselves about the ways that we can detect and seek early intervention for this specific type of cancer. So we're going to talk about that tonight. But in addition, we're going to talk about some of the other cancers that may commonly affect women so that we can learn how to prevent these cancers, what some of the risk factors are, and we'll talk a little bit about screening and some treatments. So the plan is that I would like to use our wonderful co-hosts, pick their brains, and I'll start by asking them a few questions about specific cancer types. And then at the end, you'll have an opportunity to ask any questions that you may have. And we will try to get to all of them. And if we're not able to answer your question, then we will reach out at some point soon and make sure that we get you the information that you need. All of us have been vaccinated, so you get to see our maskless faces. And thank you again for joining us. I'm going to quickly start by just sharing some general information about cancer. I think it's important to note that menopause itself is not associated with an increased risk of cancer, but increasing age is. And in fact, cancer is the second leading cause of death in women. And because of that, regular screening for certain specific cancers is recommended, and we'll go over that tonight. And what's important to know is that early detection is essential because a significant number of women will be either cured of their cancer or become long-term survivors. Tonight, we'll talk about a few specific cancers, but I think this slide can help identify what some of the incidences of the specific cancers are and the percent of deaths from female cancers. Tonight, we'll be focusing on breast, ovarian, endometrial, and skin cancer. So I'm going to start. Okay, so Dr. Thieme, can we start with a little overview about breast cancer, what it is, what some of the different types are?
Sure. So breast cancer, clearly it involves the breasts. Primarily, that's going to affect women in about 99% of breast cancers, although men can get breast cancer too. So you do need to be aware of that. Men often aren't aware of that, but of course it's pretty commonly known for women that that is one of the risks that they'll have. And one of the most significant risks, aside from being a woman for breast cancer, is age. So these are things we can't change, but we need to be aware of. As we get older, that risk for that cancer goes up. We're getting better and better at curing breast cancer. And so even though that's a very scary diagnosis for a woman to hear, over 90% of those women will survive that breast cancer. So we have long-term survivors of breast cancer now.
What specific factors would make a woman at high risk for developing breast cancer?
Well, there's a few risk factors. One is family history. Not all family histories, but when we see a family history that includes multiple breast cancers, if there are men in the family that have had breast cancer, if there are women who have had ovarian cancer, and if we've had women with breast cancer at a particularly young age, under the age of 50, we definitely look at that history as a possible risk for a genetic cause that is increasing the risk of breast cancer. And there's some things we can do to help lower that risk for those women. Most women will not have a family history and will not have that genetic predisposition. So it's not uncommon for me to have patients in the office that are very surprised they have breast cancer because they thought, oh, this only happens in certain families. And that's not the case, because 1 out of 8 women will end up getting breast cancer in their lifetime. Some other risks are things that we can change. So diet can have an effect. Weight can have an effect. We know that more obese patients are going to have a risk for breast cancer. Sometimes something in someone's history will also increase their risk. For example, radiation exposure can also increase the risk of breast cancer. And that was particularly true for patients who had lymphoma as a child and may have had a high radiation exposure as part of that treatment. That increases their breast cancer risk to the same degree that BRCA patients have for breast cancer. And BRCA is one of the most commonly known genetic risks for breast cancer. Probably the most famous person with it is Angelina Jolie.
Oh, yes.
So she found out she had the BRCA gene and actually had her breasts removed to decrease her risk. So for most women, they're not going to have a risk where we're going to such an extreme. But in BRCA patients, if you have a lifetime risk of up to 80% of getting breast cancer, trying to decrease that risk is obviously something we want to address. There are other much less extreme ways of reducing risk, though: increasing exercise, changing the diet, maintaining normal weight, not drinking excessive amounts of alcohol, because we know that can increase risk as well. And then certain medications can also increase risk. And those are the things that we try to modify, since we can't change our gender or our age.
When I was preparing for tonight's webinar, in multiple sites, it recommended exercise. And I thought, okay, this definitely needs to be my incentive.
Not only prevents breast cancer, but diet and exercise, when someone has had breast cancer, we know those patients do better. They have a better prognosis than the patients who don't exercise at all. So that actually has a huge impact, in some cases more impact than some of the medical treatments that we have. So it's really important to be aware of that and have patients be aware of that, because it can have such a profound effect. And maybe it's just that little push. So we take an extra walk around the block, because we're not talking about embracing marathons here. We're talking about exercise that anybody could do, even if you have problems with your joints or some mobility issues. There's exercise that anybody can start doing, and any of that is going to be helpful.
Which I think is the most exciting point that I hope we could make for many of these cancers. There is something that we can do to prevent them. It's not just, well, you're handed your bad genes in life, so deal with the cards you're dealt. There's definite lifestyle changes that we can make to help mitigate the risks of, I think, primary disease and recurrence.
And besides surgery to remove breast tissue, the other medical approach to reducing risk for some women will also be offering medications that can decrease breast cancer risk. So the most commonly known medication is probably tamoxifen. We use that when someone has been diagnosed with breast cancer to lower their risk. But in some women, we know they still have that increased risk over the general population. So that medication, or some other medications that are available for postmenopausal women, one commonly known one is Arimidex, are given to women because we know those women will have less of a chance of developing breast cancer. So even though they don't have a cancer diagnosis yet, we say, your risk is so high, what else can we do to lower their risk? So
if there are women that are listening that are thinking that they might be someone that's at higher risk and might need some of these interventions, what recommendations do you have?
It always starts with the primary care doctors. The primary care doctors are very on top of these type of risks, and when they see a patient that has this kind of risk or history, a lot of times they'll refer those patients to me or to a breast center to talk about how can we decrease that risk. Not only that, but how can we decrease or decrease the risk, but also increase screening for those patients. So if it does happen, we're catching this at an earlier stage. So mammograms are a commonly known screening, but there are other ways of screening, either clinical breast exams. For women who have very dense breast tissue, we might recommend other types of imaging studies, which could be ultrasound or MRI. And those women get plugged into a system where they're followed more closely, and then we can address anything that comes up on that imaging a little bit sooner.
That's great. I think sometimes it can be so scary to think that you may have a lump or be at increased risk that sometimes patients neglect to do those basic things that might result in early detection.
A lot of women, when we start that discussion, if they've had that breast cancer diagnosis and it's so overwhelming, do have a lot of fear going into that, because of course you always hear the worst case scenarios. I think for a lot of women, it's actually reassuring when they start to hear that information, that for most women, this is survivable. And of course, there are treatments that they need to go through to get there, but still, there is success at the end of that.
That's great. So you mentioned BRCA, and one of the other cancers that can be associated with the BRCA mutation is ovarian cancer. So I'm going to ask Dr. Lim a few questions about ovarian cancer. So what is ovarian cancer? Is it different than just having a typical cyst? And what are the different types?
Right, so ovarian cancer is unfortunately a cancer that really plagues women that are a little bit on the older side, usually our postmenopausal patients. And basically, it's a cancer that developed around the surrounding the follicles of the ovary. Okay, just because women go into menopause, they still have a chance of getting the cancer, and they actually have a higher risk of getting cancer. The average risk in the general population is about 65 years old or so. And this is what people hear about, the silent killer. And if you take a look at the statistics from even 2020, the risk of developing ovarian cancer, about 23,000 patients in the United States. It may not seem a lot, but the interesting thing about the number is that unfortunately, 14,000 of those patients will ultimately succumb to the disease. So if you really take a look at how many patients actually develop ovarian cancer and how many patients actually die from it, it's astronomically high. And that's why people term it really the silent killer. The problem with the ovarian cancer is just the fact that it's very hard to detect. And about 30 to 35% of the time, when it is diagnosed, it's really diagnosed at stage 3. Okay. Luckily, in individuals who have BRCA mutation, that's not the majority of our patients. It usually encompasses about 10%, maybe 12% of our ovarian cancer patients. About the remaining 30% are what we call sporadic. Actually, 60% sporadic. About 30% is really by familial inheritance that we don't even have an idea of where the genetic patterns are.
So how would a woman know if she's at higher risk for ovarian cancer?
Sure. So same thing to patients with breast cancer as well too. Number one is age by itself. Number two is a strong family history. So we're looking at first degree relative, parents, any sibling, okay, even a twin, and those are higher risk as well too. If any of those family members have any type of ovarian cancer, they are by itself at a high risk of developing cancer. Then we also take a look at secondary family history as well, cousins, aunts and uncles, grandparents. And by stratifying how many members of the family actually have these risk factors or develop cancer, they themselves are at a higher risk. And interestingly as well too, if they have a family member who have unfortunately BRCA mutation that puts them at risk of breast cancer, they are also at increased risk significantly of developing ovarian cancer.
Okay. What are some of the symptoms that a patient with ovarian cancer might have?
Yeah, so the symptoms are very vague, unfortunately, but these are the same common symptoms that you and I would normally have just from any GI upset. Okay, so I always ask my patient to just describe to me if they have what we call bloating sensation. Okay, if they're just really feeling bloated, it's out of the ordinary. If they're noticing that their belt is fitting a little bit tighter than usual, okay, Commonly also the rings that they wear, if it's getting tighter and tighter as time is going on, because we may not gain a lot of the weight and the fluid around the abdomen, but we're retaining fluid from the ascites that build from the cancer and it's accumulating in the body, okay? Other things include what we call early satiety, is when you're getting full a lot earlier when you're eating and you're noting that as a progression. Nausea, vomiting, constipation, or even diarrhea, just an alternating type of your bowel habits can also give you that inkling signs. Now, I know probably a lot of women and men may have those symptoms.
I'm
okay?
thinking, oh my gosh.
and luckily, the majority of time we're not. But unfortunately, just based on the lack of screening modalities that we have, those are really the signs I really educate my patient on, and for them to be very vigilant about looking for those type of symptoms.
Okay.
If you do have a patient with BRCA, what's the conversation with them as far as, like I can recommend potentially removing the breast tissue. Do you have a certain age that you recommend that by?
Yes. So, more commonly with the BRCA1 mutation, the recommendation is really by the age of 35 or done with childbearing. Okay. So if I have a young female who's 30 years old and she has 3 kids in a healthy relationship, not planning any more children, then that would be the good time for them to have the risk reduction as well. And the risk reduction would include at least removing the ovaries, the fallopian tube. And just recently, in the last 1 to 2 years or so, we also know that patients who have BRCA mutation have an increased risk of developing a serious endometrial cancer. So now I'm also recommending to have a complete hysterectomy in those subset of patients. And then, of course, I will have to refer them to see you. And with the BRCA2, it's a little bit more lenient. The standard recommendation is really a little bit later. So you're looking at the age of 45, in which you should really counsel patients to have a risk reduction surgery. And what we've really found is that patients who actually have risk reduction surgery at an earlier age tend to have a better long-term overall prognosis in terms of just developing cancer of the ovaries and fallopian tube, but also from a breast cancer perspective as well.
Okay. And is there anything that a patient can do to decrease her risk of ovarian cancer?
Yeah, so, unfortunately, the risk itself, the inherent cause of the cancer is really through fallopian tube and ovarian mutations, okay? And like we talked about earlier, there's really no way to change the sex or the age or the genes. But I always counsel my patient, again, very heavily on, keeping proper hygiene, eating healthy, exercising. And I think that seems to be the common theme of what we're really kind of going for. But in terms of self-prevention, I think just understanding and knowing your body and understanding the signs of something that is not right, I think that's really the best that we have right now, unfortunately.
Very often in my menopause clinic, I have patients who may have had a hysterectomy, don't need a pap smear necessarily, and they ask, do I need to come to the gynecologist every year? And what would your thoughts be about that relative to ovarian cancer risk?
The answer is absolutely yes. Okay, and the reason why is that a lot of women, they equate getting pap smear with seeing their with their gynecologist. And I always counsel my patient that even though you don't have a cervix, you may have decreased risk of developing cervical cancer. They may not do a pap smear, but an annual pelvic examination by your primary care provider or OBGYN is always very important, because that's when you can actually diagnose pelvic masses. And it's important because, a lot of women may skip those type of visits. And I think it's prudent for women to be very diligent about, following up. And that also promotes their own health and able to develop a relationship with their provider so they can have an open communication on these type of cancer risk.
Okay, ladies, you heard that. Annual GYN exams. So let's change gears and talk a little bit about skin cancer. Dr. Thieme, can you tell us a little bit about skin cancer?
Not the 2 most common cancers for women. I got breast and now skin.
No pressure here.
So skin cancer either can be not a big deal, easy to cure, not really going to cause any problems, to catastrophic and life-threatening. So we're talking about a huge range within that category. One of the things that's sometimes a surprise to patients that cancer is not necessarily cancer is not cancer. There's variations, and it's not all one cause or treatment. So there's basically three main types of skin cancer: basal skin cancer, squamous cell, and melanoma.
Okay.
Basal cell is the most common. It presents as a changing lesion, can look very pearly or pink, does not typically cause pain, and just grows and creates this often non-healing wound. And that can go on for years. It creates a local wound. It's very unlikely to spread in the rest of the body. And the treatment for basal cell is basically removing it surgically.
Okay.
That can cure it. So very unlikely for that to spread in the rest of the body, which we call metastasis. And that's when cancer gets scary. Squamous cell is the next most common one. It's a little more aggressive than basal cell, but for the majority of patients, again, we can surgically remove it. It's usually just a local problem and a local wound that never quite heals. Melanoma is a very different skin cancer. That's the one that is more typically life-threatening. So even though basal cell and squamous cell are much more common for skin cancers, melanoma is 75% of skin cancer deaths. That's what patients have heard of before, a mole that starts to change. It gets irregular in its shape. It's getting larger in size. It can start to itch or turn into this non-healing wound. Typically, it's really dark pigmented, although there are variations of melanoma that don't have that dark pigmentation, as well, what we call amelanotic melanomas.
Oh, wow.
Yeah, so, and occasionally that can be a surprise where something looks like a squamous or a basal cell, and then that pathology returns and it turns out to be that variation. So melanoma typically needs more than just surgery to treat. If it's a later stage melanoma, sometimes we'll have radiation treatment, sometimes chemotherapy, but that's when we start to look at more of a multidisciplinary approach to the treatment because of it being more aggressive cancer. For some patients, though, we'll catch that melanoma early enough that surgery is the only treatment we need. And then we just know for any of these patients with a skin cancer that they need to be followed really closely, because once you've had it once, you're at higher risk for getting a new breast cancer. And that's true even with the basal and squamous cell cancers, that you're at higher risk also for melanoma. So we really want to watch them closely in case they would develop that scarier type. The only risk factor that we haven't talked about besides the exercise and all that is sun exposure. And that's really going to be key in someone's skin cancer risk. That is something that we can modify. So squamous cell and melanoma rates decrease with the use of sunscreen. Actually, basal cell does not. Sunscreen doesn't help, but having a protective layer of clothing, not being out in the midday sun, that can be helpful even for basal cell. Okay. So there's things we can modify. With skin cancers too, though, your genetics are going to create some risk. Certainly fair skinned patients are going to be at higher risk for these skin cancers. And certain medications, again, anything that suppresses the immune system increases your risk for skin cancer.
Okay.
And smoking.
So
we got smoking in there for which we would eventually, but skin cancer risks do go up with smokers.
Okay. So can you repeat the few things that patients might look out for if they have a skin lesion?
Any changing skin lesion that's just never quite going away. So for basal cell, I'll have the patient that says, yeah, I knocked myself like last year and then that wound just never quite healed. That history always worries me a little bit, that might turn out to be a skin cancer. Okay. For melanoma, it's definitely that irregular shape, that increasing size. Dark pigmentation definitely is a concern. So a mole that's now getting much more darkly pigmented is something to worry about. Or you can see it with melanoma where you have a mole and then you start to see other dark spots appearing in that area. And that can be a melanoma that's now marching out from where that first site was. Okay. Any sun exposed area is at higher risk. For men, the higher risk is back of the ears and back of the neck because they're out working more. Women, it's the legs because we wear skirts and we let sun hit our legs.
Oh, wow.
So the back
I wouldn't have
legs.
thought of that.
So any of those sun exposed areas are going to be higher, but patients can get melanoma in any area. So we can also see it underneath the nails in the hand and in the toes. And that sometimes can get tricky to diagnose because that might just look like the nail bed is bruised, but it's actually a melanoma that's brewing.
Wow, that's some good info.
Yeah.
Okay, and then let's just talk a little bit about endometrial cancer. And I know I'm jumping around a little bit, but we're so lucky to have these wonderful experts here. So, Dr. Lim, what is endometrial cancer? How is it different from other types of uterine cancer?
Sure. So, endometrial cancer is the most common type of female gynecologic cancer. Okay. It probably encompasses about 60% of all the female GYN cancer itself. And, interesting you ask is every time when I see a new patient, they get very stressed out coming to the office. And I always try to relax them. And one comment that I always let them know about is that, and I tell them, if I was female and if I must have a cancer, this is the one that I would want. And the reason why I say that is because majority of the time it's treatable. Okay. And I always let my patient know that, the endometrial cancer really is a disease where the lining of the uterus is just overgrowing its normal process. And again, with age, it happens a lot more in patients who are postmenopausal.
Okay. How would a patient know what symptoms would she commonly present with if she had an endometrial cancer?
Yeah, so with our patients who are, postmenopausal, they would have bleeding. And I just want the audience and you guys to know that, women will subsequently tell me, well, I only had a little small spot, so I just ignored it. Okay. And I always tell my patient, it doesn't matter how much or how little, any small spot, whether it's brown, red, or black, it doesn't matter. Okay. I consider that some form of bleeding.
That's a good tip right there.
So, and a lot of women, they try not to go to the physician for it because they just kind of pass it through thinking it's just, because they went through menopause, it's one of those things they would experience. But it's always very important to know that for patients who are menopausal, that any type of bleeding or suspect of bleeding, you should always check out to make sure it's not really coming from the lining of the uterus. And that's what really makes it very treatable because that's usually the first common presenting signs.
Okay, so vaginal bleeding.
Vaginal bleeding. And in our younger patients, is if they have any type of irregular bleeding habits. Maybe it's bleeding in between their cycles or their cycles going a little bit longer because these women are usually more accustomed to getting their menses. So how do we track that is really by the abnormality of their normal flow.
Okay. What are some risk factors?
Sure. So, again, like I said, age is probably one of the defining risk factor. Unfortunately, we can't change our age.
I'm trying.
The other is really things we can modify is unopposed estrogen. And what do I mean by unopposed estrogen? Women who take any type of exogenous therapy, for example, therapy that are very common to reduce other side effects in terms of women, they want, increased libido status, increased sexual activities. They'll start taking these hormonal therapies. And also women who are a little bit more on the obese side, they have a little bit more adipose tissue. And there's really no ideal in terms of if you reach this amount of tissue, you're going to increase your risk. But we know that the adipose tissue is going to increase your risk of having excess estrogen. And that actually stimulates the lining of the uterus to become a little bit more thick and to progress to cancer. Okay. Some of the other things similar to breast cancer is also history of radiation. Okay, if individuals have had history of radiation, commonly again like lymphoma, okay, to the abdominal pelvic area, they in that instance they will also be at increased risk of developing endometrial cancer. And another one that's really popular is patients who are on some form of hormonal suppression therapy or hormonal therapy for breast cancer. Now, not all patients who are on tamoxifen will get some form of endometrial cancer, but they will develop some form of abnormal bleeding at times, and they may develop what we call endometrial hyperplasia, which is a precursor to endometrial cancer.
Okay. That's some very good information there. And I think one of the most important take-homes are that in the postmenopausal patient who has not had periods for more than a year, any type of bleeding, you should alert your GYN or PCP so that it can be further evaluated.
Definitely. And I wouldn't just ignore it.
Yeah. Well, I think that we'll go to some audience questions. What do you guys think?
Sure.
This is very interesting. So I'm just going to read it.
Okay,
I had
great.
a complete hysterectomy and take Premarin. I have been on a yearly mammogram regimen since I was in my 20s due to density of breast. I'm on lowest dose and have been concerned about moving it up. I still have some hot flashes, however, not as bad, mostly during the 7 days I'm off the medication and a few days into starting the medication again.
Okay, well, so I think that this is a question that, although the specifics may differ from woman to woman, is common in that patients often worry about risk of breast cancer when using hormone therapy. And we know that, I'll give you my opinion and then I'll have Dr. Thieme add to it. There are certain factors that would increase someone's risk for breast cancer, and having a history of breast dense is one of them, because we might not be able to detect an early lesion as early as we might in someone without dense breasts. But like so much of medicine, the decision to start hormone therapy is pretty individualized, because there are some benefits aside from it being the most effective method of treating hot flashes. We know that there are several different types of estrogen that can be used, and the types can, data has been increasingly showing that different types may correspond with varying risks for breast cancer. But we don't want to have someone be on it if they don't need it. So what I would say is that anyone that has a concern for having an increased risk for breast cancer, that they really need to talk with their provider about their specific breast cancer risks, and then go from there. So it's definitely not a off the table question, but it might be worth talking about what, if any, different formulations might pose a lower risk. And then discussing whether increased surveillance might be recommended.
Yeah, for breast density, it's not only that mammograms don't work as well in those patients, there is a slight increase of breast cancer risk in those patients. It's not dramatic, but it is an increased risk. So other modalities like ultrasound or MRI might be recommended. Fortunately, in the last year, the state of Pennsylvania passed a law, SB 54, that required our insurance companies to cover MRIs for women who were found to have dense breast tissue on mammograms, because that was a real battle before. So those can be a better screening tool. It's not a very comfortable study to get through. So for a woman who has claustrophobia, that might not be a good option to routinely be doing breast MRIs. But it is a good way to screen denser breast tissue because it looks through that and it's not affected the way mammograms are.
And is that typically in lieu of a mammogram or in addition?
In addition.
Okay.
In addition, nothing gets us away from mammograms. So
darn it.
Yeah, sorry.
For the average age patient, when should they begin having mammograms?
Well, different societies have different recommendations. And when you ask a breast surgeon, we're going to definitely lean towards the younger recommendation.
Yes.
So
gynecologists too.
Yes. So we recommend starting at the age of 40 and then continuing every year. A few years ago, there was a big blow up because the United States Preventative Task Force said, you don't need to do that until the age of 50, and then it can be every other year. Their criteria for making that recommendation was not that we're not detecting breast cancers in the 40s, because we definitely are with mammograms, but we do have a fairly high false positive rate with mammograms, meaning we get all excited about seeing a spot in there. We put women through a lot of anxiety, maybe even biopsies, maybe even surgery. and it turns out to be nothing. So there was that cost and that anxiety that there was a concern. And that was actually a big part of the criteria where they said we can hold off until the age of 50. Again, we see women in their 40s with breast cancer. That is absolutely a group where we want to be intervening before this is something that they can feel or that's causing symptoms. So breast surgeons rarely follow that recommendation, just to wait till the age of 50. The other concern I have with those recommendations is a lot of that data was built on Caucasian women. Mm-hmm. And when you have non-Caucasians, the African Americans and people of color, they're at higher risk for getting breast cancer in the 40s. So there may be some bias in that data that we're not capturing if we would follow that. So we recommend at the age of 40. Sometimes if there's a strong risk, like the BRCA patients or there's other genetics besides BRCA that really increase breast cancer risk, we'll start mammograms down to the age of 30 even, but that's not typical for other patients. And the reason is because the breast tissue is typically dense in all young women. Mm-hmm. So mammograms are not going to have a lot of value as a screening tool. And we typically use more ultrasounds. If someone's a teenager or in their 20s, maybe an MRI if we're really concerned about something.
Okay, that's helpful.
Thank you very much. So we mentioned Premarin at the beginning of this question. Here's another one. Can you talk about the risks associated with the use of Premarin cream for postmenopausal vaginal atrophy and UTIs?
Okay. So there's two kind of flavors of hormone therapy that I call them flavors, but women can take hormones that would be systemic, so they get everywhere in your body, or they can use hormones locally, and that would mean using estrogen at the vaginal tissue directly. So it's absorbed locally into the vaginal area and helps treat those tissues, but typically does not raise a woman's blood estrogen levels. And so that can be a very effective, it is the most effective way of treating vaginal atrophy or genitourinary syndrome. And because when women go for a prolonged amount of time without estrogen exposure, it changes a lot about the tissue in our vaginal and vulvar area. And in addition to making the tissue drier and changing the pH, it also changes the architecture in a way that makes it easier for women to get bladder infections or UTIs. And so by restoring the natural state of the vaginal tissue by using local estrogens, it may decrease that risk.
Okay, I have another question for you that this is a tough one. I'm just going to read it. I have two questions. Number one, my mom just passed away from, I'm not sure. She wrote GIST. Could it
just
be breast?
Mm-hmm.
Oh, okay, / abdominal cancer. She was diagnosed and died within 2 months. I'm so sorry to hear that. What can I do to prevent this?
Doctors, that is a tough one. And there's just tumors. There's not a lot in prevention for just tumors. That's a very specific type of abdominal cancer. We're actually better at treating those. So if it's an earlier stage, that can be amenable to surgical resection, and there are chemotherapies that are quite effective on it. But unfortunately, with some of these abdominal cancers, they present so late with symptoms that it has spread in the belly before we have the ability to do a surgical resection or before chemotherapy is really going to provide benefit. And unfortunately, it sounds like that was probably the case with her mother. For prevention, probably we don't have a lot of data to help, but screening might be where it can be helpful for a patient like this. And so for cancers that start in the stomach, sometimes we'll recommend that patients undergo an EGD, which is where we put a camera down into the stomach and take a look and see if there's any growths. And in some cases, we will accidentally find just tumors that are 1 centimeter in size, half an inch, and those can be resected and really no other treatment is needed. So a GIST tumor in and of itself is not necessarily a dangerous tumor. A lot of times that's curable, but it's another case of resecting that early ends up making it much easier for the patient to get through treatments because we're doing less and makes it survivable.
I am sorry that you had to go through that, and perhaps talking with her PCP about
absolutely about what risks that she might have. And of course, as with any of this, you're being proactive already, thinking of what can I do, and that is the biggest take home with any of these cancers is being proactive yourself. If you feel a symptom, pursue it, let your practitioners know, and they can point you in the right direction or get you these screenings. Sometimes even if it's just for peace of mind, it's well worth going through that screening because the stress of having gone through what you saw your mother go through is significant. So there was a second question there.
Her second question is, she suffers from anxiety and depression. Her family doctor wants to put her on SSRIs. Could it be menopausal? She's 56 years old and had a hysterectomy 20 years ago.
10 years ago.
10 years ago, I apologize.
So the question about mood changes and depression and other mood disorders and how they're related to menopause can be a tricky one because we have patients who may have some underlying mood issues, and then when they go through menopause, they seem to become exaggerated. But what's tricky about it is that in addition to the menopause being a time when our hormone levels change, other things are going on. Often kids are maybe leaving, going to college, careers may be changing. And so it can be difficult to know that a mood disorder is hormonally driven. But I certainly have worked with patients who their mood disorder is very hormonally sensitive. And sometimes when we use hormone therapy to treat other symptoms like hot flashes, the mood disorder is improved. So I don't mean to keep going back to this phrase, but really it becomes an individualized discussion that you should have with your PCP and or gynecologist. What participants who may have been here for previous chats have heard me say is we spend a significant amount of our time in perimenopause and menopause. And so whatever you may be experiencing, it's never, in my opinion, the right answer to just tough it out, it'll be over soon, because many of these symptoms, like the mood changes, are very easily treated. And we would, often early detection and early treatment is much more effective than delaying.
So I have my own question about that, because she stated that her doctor is just really focused on the SSRIs. Perhaps that doctor is just not aware of everything that you've just been talking about, and it wouldn't hurt to visit a GYN or make an appointment with Dr. Ochalski just to get some other ideas. And it's certainly, I'm not saying anything negatively about her PCP, of course not, but sometimes it's nice just to hear from someone else.
Yeah, sometimes when you have a hammer, everything looks like a nail. And so just talking about the possibility that hormones may be influencing her mood is worthwhile.
And just for the peace of mind, if she does get on an SSRI,
Yes.
she knows that she's explored other options and
Yes.
feels more comfortable with that treatment plan. I always encourage my patients to get a second opinion because that information can be helpful. They feel better about a treatment plan. And sometimes, even if you're saying the same thing as another practitioner, the way I explain it and the way they explain it, maybe their way is clearer to that patient. So it's always worth getting that information, even if you end up going back to the same treatment plan that
Agreed.
was at the beginning.
Agreed.
Thank you. Okay, since vaginal use of Premarin doesn't carry the same risk of raising systemic levels of estrogen as oral use, does that mean there's little risk to prolonged years use? In other words, is it okay to use it for the rest of my life if it is useful in managing symptoms?
Well, that is an excellent question, and I'll take the opportunity to generalize a little bit. But when we probably 10 years ago, the rule was take women off of hormones as soon as you can, and definitely after 10 years of use, and or by the time a woman reaches 65, she needs to be done taking hormones. And now, as we have different hormone preparations, and specifically hormone formulations that are very similar to what the ovary produces, we have increasing data that extended duration in a woman who needs it can be a safe option for her. So in general, I don't think there's this for most patients, there's not a magic cutoff date where you have to stop your treatment, but you do need to talk with your prescriber, whoever's prescribing that medicine, and know whether it is worthwhile for you to continue. So it's not a, here's 5 years, come back when you need me. But specific to vaginal estrogen, because it doesn't raise systemic levels of estrogen, there's even less of a concern about coming off of it with urgency. And unlike many of the typical menopause symptoms, most of which will eventually go away or rebound, the vaginal dryness or vaginal atrophy is progressive. It never goes away. So many women do need to stay on some form of treatment for the duration of their life.
Yeah, and kind of just to add to that as well, too, the fear of using estrogen stemmed really from the Women's Health Initiative in the early 2000s, and also the nursing study as well. And basically what they were actually trying to look for was decreased risk of getting cardiovascular disease. Now, if we really take a look at that data by itself, the average age in that trial was about 63 years old. About 30-40% of those patients were smokers, they were hypertensive. And the question that they really didn't ask, which they really should, was that, does this really affect the quality of life? Mm-hmm. And what we actually found as the pendulum swings back and forth, like you mentioned, Melanie, is that we're kind of swinging towards a side where we're starting to use a little bit more of the hormonal therapy. And I totally 100% agree with you about the local benefit of being on Premarin. And what you find is that if women are using the medication and they're having good quality of life and they're not having any issues, they're healthy, they're exercising, eating well, leave them alone. Mm-hmm. Leave them alone, okay? And from my perspective, I do prescribe hormonal therapy, especially in some of my younger patients who had a hysterectomy. But again, like you said earlier, that discussion is really individualized from patient to patient on whether or not hormone will benefit them. But I 100% agree with you that, estrogen and the topical cream will give you different effect, and we really have to check and find out to see what really the symptoms are and what we're actually trying to treat.
Yeah. Even in breast cancer patients will use it and feel comfortable using that, even though in general we want to decrease the estrogen exposure. But unfortunately, some of the treatments that we have are anti-estrogens. That's going to decrease your breast cancer risk, but it actually increases women's symptoms, and vaginal dryness is one of the main ones. So even in these patients where obviously we're handling them with kid gloves because of this recent cancer diagnosis, we feel comfortable with them being on Premarin.
I think I'm glad that you both mentioned this because a lot of my earlier slide
Mhm.
mentioned how good cancer survivorship is. The consequence of that is that we need to treat women who are going to live for hopefully decades with some of the consequences of those treatments.
Right.
Absolutely.
So even recently, with patients who have endometrial cancer, who we know is estrogen dependent, the guideline actually changed recently and actually allowed us some leeway to actually treat these young patients with some estrogen therapy, okay, just to improve the quality of life, okay. Now, of course, the guideline specified individualized.
Always.
Okay, but they're not restricting us from using. So it's good to know that they're actually understanding that quality of life is really important as well, not just treating the cancer by itself.
That's so true in many of the different kinds of cancers, is that we've really backed off the aggressiveness of a lot of the treatments while still maintaining, or in some cases, for example, in breast cancer, we've actually improved prognosis even though we're doing less. So we used to be very aggressive with the breast surgeries and removing not only the breast but the muscle underneath and all the lymph nodes in the armpit, and we've really backed away from any of that real aggressive surgery. Also backed away from the use of chemotherapy in a lot of women. That does not end up being a part of their treatment plan because we've got anti-estrogens that are, if anything, more effective. So in general in cancer, we're trying to back off and still give good treatments because the quality of life can really be affected otherwise.
I just had an idea for another menopause chat, which is cancer survivorship and improving quality of life. Sue,
okay, I made a note of that, Dr. Ochalski.
We got to put that on the books.
Okay, one of our participants came into our discussion a little bit late, and she would like you to, if you don't mind, talk about BRCA again, and how do you know if that's something that you need to worry about?
Sure. So at the end of the day, how you diagnose BRCA is going to be through genetic testing. So even if you have a strong family history, even if there are other family members that have BRCA, as an individual, you need to be tested. And most cases, that's going to be a blood test. Sometimes we'll do a mouth swab and we can do the testing through that. So that's really where you're getting the answer. I think probably the real question is, how do you get to the point where you know to undergo the testing? So family history is going to be the strongest indicator. Multiple family members with breast cancer, women in the family that had breast cancer at an unusually young age. Any history of ovarian cancer, because we had mentioned earlier, 10-12% of ovarian cancer patients carry the BRCA gene. So anytime I hear that in a woman's history, that's an indication for genetic testing. Anytime there's a male in the family that had breast cancer, that's going to be a much higher risk in the BRCA families. So that also is an indication. I have had many patients, though, that presented with breast cancer at a young age. There was no family history of breast cancers, ovarian cancers, and just their young age prompted me to get genetic testing, and they did have the BRCA gene. So sometimes you don't have that family history that's really going to guide you. So this is something, if you have a concern or if you're wondering if your family history is putting you at risk, absolutely bring it up with your primary care doctor. That's a common reason to refer patients, is to have that conversation, is, do I have a family history that warrants this testing?
Dr. Thieme, that's very interesting. I actually have a question to ask. And
okay.
Are there any specific ethnic groups that you may know that would actually put them at increased risk of having the BRCA mutation?
Yeah, the one that comes up over and over again for genetic risk is the Ashkenazi Jewish heritage. There's several significant genetic risks for that Ashkenazi Jewish heritage. So they're a higher carrier of the BRCA genes. One thing I'll mention about BRCA genes, people wonder BRCA, and that sounds like one of our mysterious acronyms, and it's going to be some crazy Latin word, but it literally stands for breast cancer, BRCA. So So there's BRCA1 and BRCA2, but even within BRCA1 and BRCA2, that's not just one set gene.
Right.
So there's a certain kind of BRCA that people with Swedish heritage can have, or Ashkenazi Jews, or other ethnic groups. But yeah, there are sometimes where it's going to be more common.
Okay.
Well, I think you all are incredible. And I thank you so much. I have learned so much tonight.
So have I.
And it looks like you have answered our participants' questions in full. So I thank you all very, very much. I do want to ask the participants to just stay online for a minute or two after our doctors say their goodbyes, just because I have screenshots that will show you how you can get in touch with any of them.
Well, I have one closing slide, and it's just a summary of some ways that we can modify our risk of cancer. Get to and stay at a healthy weight throughout life. And that's a plug because our next menopause chat is about nutrition. So please join us in November for that menopause chat. Be physically active on a regular basis. Follow healthy eating patterns. Avoid or limit alcohol. Don't smoke. If you have a cervix and you're older than 25, have cervical cancer screening and talk to your gynecologist about when you might be able to stop or start spacing out that pap smear. Even if you don't have a uterus or cervix, still see your GYN every year. Mammogram starting at 40. Colorectal screening. And that can be done in a variety of ways, including stool tests or colonoscopies. So talk to your PCP about when to start that. Limit sun exposure. I think the discussion about skin cancer is always a little bit frightening, but something that we can do so much to prevent. And then I think the take-home message is have good communication with your doctors. If you're menopausal and are having bleeding, if you are feeling a lump or have any concerns about your specific risks of any of these cancers, please talk with your PCP. We have such a great community of docs, and I'm really honored to share the screen tonight with you guys. Thank you
Thank you very much
for joining us.